Our given week was in mid-December when we stationed our photographers at the Prairie Heart Institute at St. John's to document some of the multitude of experiences of patients who arrive at one of the Midwest's largest heart centers. Like Dovey Heaton-Bergen, whose family brought her here when it became clear she had suffered a stroke, and George Lackey, whose atrial fibrillation was putting him at risk for stroke. Dr. Mischkel, it is so interesting how the heart figures into everything that goes on with our general health. We have two patients here. One has already suffered a stroke.
Right.
Another one who is at risk for stroke. And they have very different heart problems, but the heart figures into it all over the place, doesn't it?
Well, stroke is a huge medical problem. It's the fourth leading cause of death in the United States, and actually the leading cause of disability. And stroke has a myriad of causes. I think that a lot of people think when you're talking about a stroke that you're talking about a singular entity, but in fact a stroke can be a bleed in your brain, a stroke can be related to plaque in the artery to your neck, but a stroke can also be caused by your heart, either fibrillating, atrial fibrillation, and for things like that, we want to prevent stroke, we put them on blood thinners. And then there are strange abnormalities of the heart that we discover after you've had a stroke, perhaps a clot in your heart, or a tumor in your heart, or a hole in your heart, and those can cause stroke.
Right. In this program, we're going to see how Dovey, who has what we call a hole in her heart,
Correct.
is going to get that repaired. And in George's case, a situation where he's got that AFib going on.
Right,
we're going to describe that and also show how that can be remedied just with a laser. Amazing.
It is. It's one of, he represents the end of the spectrum in terms of patients who have atrial fibrillation. The vast majority of patients with atrial fibrillation can be treated medically, their heart rate controlled, put on blood thinners, stroke prevented, symptoms go away. But of course, at the end of the spectrum are patients who can't tolerate medicines, or it's just not working for them. And again, doing an ablation to restore regular rhythm is the next best thing.
Well, we're going to pick up the story first with Dovey, who's going to tell us. Her daughter is going to tell us how they discovered her sickness and how they took care of it.
Looking forward to it.
So your mom in September had a stroke.
Yes.
And how did she know that she had a stroke?
She felt off. She was at work. She felt that something was wrong, and she managed to drive home, got home but couldn't figure out how to turn her car off. And she started calling, and she got a hold of Tyler, her grandson, and got him through mumbling that something was off. He got to her, and she wasn't able to complete sentences. She wasn't able to complete a thought. Couldn't come up with words that normally she would no problem with.
Connie's mom, Dovey, had been at work decorating cakes when she knew something was wrong. She drove herself home, then called for help.
I just wanted to get out of there because I knew that if somebody spoke to me, I couldn't speak back. I knew that I wasn't going to be able to speak to them. And I went and got in my car and drove home in a full-blown stroke.
Oh boy, you were lucky that you didn't have an accident or run off the road.
You know
or
what?
something.
I just knew that. I just knew that I could do it. And I got home and I made some calls to people that I wasn't supposed to, trying to get a hold of him or her. and I finally, after about the fifth or sixth try, I managed to get him. I couldn't get my car keys out. And I didn't know why I couldn't get the car keys out. I managed to get the car turned off, but couldn't get the car keys out because I hadn't pushed it out of gear. I didn't know that. And when I got, I just got down the chair. If I'd got in the house, I probably wouldn't have called anybody. But I couldn't get in the house. And I sat down in the chair. Finally he answered the phone, and I just said trouble, didn't I?
Yeah,
trouble.
that was all you said.
Trouble.
That's trouble.
Yeah, that's enough.
And he said, Grandma, is that you? And I said, yes. And he said, what's the matter? And I just said, trouble. And he said, are you at home? And I said, yes. And he said, I'll be there. And I don't know how fast he drove, but he got there pretty quick. He got there.
Subsequent tests showed Dovey had a septal defect, a hole in her heart, that likely caused the blood clot that led to her stroke.
Hello, how are you?
I'm okay.
So,
It's been a while since I saw you. Have you had any problems since that time? No. So you haven't been back in the hospital? You haven't had any more events with
I went back to
speed?
work.
You went back to work? What are your...
I decorate cakes at County Market.
Oh, that's right. I remember that. Yeah.
I teach school, but I've not had any classes to teach yet. So.
Okay. Well, it's my daughter's birthday soon, so maybe I'll have to come to County Market and get you to decorate the cake.
I can do it.
Okay, perfect. So you know what we're going to do today. Okay, so we're going to go in through the vein in your leg. So we actually go in through the vein on your left groin and the vein in your right groin. So on the left-hand side, what we'll do is we'll put up a special echo probe that we can use to take a picture of the defect in the atrial septum. And then what we'll do is on the other side, we go up with a catheter, cross the defect, put a wire in, and then over that wire we will put the device and then deploy the device. So everything should be fine. As you know, there's risks, but there's risks with not doing anything. And the hope here is that if we get a good result, and we're anticipating getting a good result, that we can get you off the Coumadin, and you'll be on aspirin, and then you'll probably be on Plavix for about 6 months or so. Okay? You're raring to go? Not really?
It's got to be what it's got to be.
Yeah. And we'll give you some medication to help relax you. You'll be relaxed. Okay.
Can I walk when I get done?
Yeah, you know I sure hope so.
When you go on both sides, I thought,
right.
boy, I'm going to.
No. You'll have to lie in bed for a couple of hours, and then you'll get up and be able to walk. So it's the vein, not the artery. So you can still get a hematoma or a collection of blood, but it'd be unusual. And yeah, you'll be able to get up and walk. You'll have some discomfort for a couple of days, and we'll ask that you not lift anything heavy, or perhaps squeeze the cake tube too hard, the icing tube. So, but you'll be able to walk. So, okay.
Yeah,
and and I think you'd probably be able to go back. When do you work on the weekends, or you just work Monday?
I make my own schedule.
Okay. Yeah. I would think probably 3 to 4 days you should be able to go back to work. If that's what you want to do.
That'll be good.
You can always make it longer. But. All righty? Okay. All right. So they're going to come and get you, and we'll get started.
Meanwhile, 78-year-old George Lackey of Centralia has arrived. His atrial fibrillation, or AFib, is a heart rhythm defect that can cause blood clots and lead to stroke. Unfortunately, though, not too long ago, you found out that you had a cancerous tumor. And in the process of learning that, you also found out that you've got this atrial fibrillation. Huh?
That's correct.
Yeah.
They had me on a heart monitor during the needle biopsy procedure, and then it showed problems with that AFib.
And then I guess the doctors recommended, well, let's get this cancer taken care of. And when you get your cancer taken care of and you're on solid ground again, then we'll take care of this AFib.
That's correct, and that brings me here today.
So what does AFib feel like?
Nothing.
No?
I feel no symptoms whatever.
You just found out because of a test?
Yeah, well, it showed up on the monitor by accident.
Yeah.
And then, of course, I went to see Catholi again right away, and he did an EKG, and he found it rather quickly. Yeah. And determined from that what it was. And so here we are, ready to get it cured.
We are.
The heart is formed of 4 chambers. 2 top chambers, each one called atrium, and the bottom chambers, each one called ventricle. The top chambers are more helpers. The main pumping chambers are the ventricles, and the bottom ones. Each heartbeat starts by an electrical signal from the heart's natural pacemaker that we're all born with. This pacemaker fires the signals, spreads to top chambers, make them squeeze. They move blood through the heart valves to fill the bottom chambers of the heart. Then that signals travel through this cable to activate the bottom chamber to squeeze, and that's what ejects blood out. That's what we feel as a heartbeat or a pulse rate. We don't feel the beating of the top chambers. Now, in our hearts, the sinus node is the natural pacemaker. That's the only place where signals are generated, and that's what drives the heart rhythm. nowhere else in the heart should generate electrical signals. In your case, the heart learned to generate signals from outside the natural pacemaker, somewhere here in the right top chamber of the heart, the right atrium. Instead of these signals, the normal signals come at 60, 70, 80 a minute, speeds up when you're active, slows down when you're at rest. But now with your arrhythmia, the signals are coming very fast, at about 300 a minute. So the top chambers, instead of squeezing at 60 a minute, they have to do it at 300 a minute. They end up quivering or fluttering. That's why we call it atrial flutter. Now, this will affect you in two major ways. When the top chambers quiver instead of squeezing, they're not really helping in filling the bottom chambers, the pumping chambers. So the heart efficiency as a pump is much less than normal. Less blood is being pumped to your muscles and the brain and the lungs. Patients get tired easily, no energy. Many patients will complain of shortness of breath when they walk around. Some will get lightheaded. Some will feel the heart beating fast, but others do not. The other big problem is when the top chambers quiver, blood stays still inside those chambers. And in the creases of the heart muscle, blood can clot. Those clots, if they break loose and travel with the bloodstream to the brain, they can cause stroke. That's why blood thinning is very important to prevent stroke. So what do we need to do? First, we're going to thin the blood to prevent stroke, and we already started you on a blood thinner for this. Second, we'd like to stop this rhythm, and we do a procedure called ablation. This involves us going through the groins up to the heart with several catheters that record electrical signals. And we map where's that electrical signal coming in the right top chamber of the heart. We identify the location, and then we cauterize that location. We deliver radio frequency energy to burn out, if you will, that spot that fires the fat signal. That's called ablation.
But first, Dr. Issa wants to make sure there are no blood clots in the heart. So, Dr. Ashraf Eldada will take an ultrasound look at the heart via the esophagus.
Doctor, why does Mr. Lackey have to have this test that you're going to do before he goes into the cath lab?
Basically, this procedure is imaging. Essentially, the arrhythmia that he has puts him at risk of developing blood clots inside of his heart. And what we're doing before proceeding with this procedure and disturbing clots within his heart, we want to make sure there's an absence of any clots inside of his heart.
I see.
So it's preparatory for the actual procedure itself.
So how do you actually perform the test?
We put him gently to sleep. We call it a twilight sedation. And it's amnestic and hypnotic, so people forget what really happened in there. We use lidocaine for the back of the throat to anesthetize it, essentially, and this allows passage of the probe through his throat and into his esophagus. Esophagus sits right behind the heart. It gives us a bird's eye view.
The ultrasound showed no evidence of blood clots. Dr. Issa could go ahead with the ablation procedure. Meanwhile, Dr. Gill is preparing to place a device in the hole in Dovey's heart that will keep blood from flowing from one side of her atrium to the other. Pretend this hand is the septum as you see how the device seals the hole.
This is the device. We're going to load it into the delivery device. And it's a set of nitinol rings with the PTF attached. So now that it's in the device, then what we do is the wire goes through here and out this little port here.
Okay.
And then we place it into the left atrium. And so Paul's going to pretend he's the left atrium. So we push this out. And then we pull back to start forming the curve.
Wow.
And is it 2.5? So there is the left atrial side right there. So then we pull this back against the septum.
Okay.
We expose it, and then yes, right. And we push out.
Ah, so it seals both sides, huh?
Oh, it has to. It has to be on both sides to seal it. Yeah.
Aha.
Okay. Here we go.
Perfect. The device will be delivered by catheter through Dovey's blood vessels to the heart. First, an ultrasound image will show Dr. Gill where the hole is.
Okay, so you can see color, and you can see that there is a wire that is going in a direction that's actually going across the intraatrial septum, and then you can see color going back and forth there as well, which indicates that there is communication between the two chambers, which there shouldn't be. So there's blood flow occurring between the two chambers.
And that we would describe that as the hole.
That is the hole. Yeah.
Now, to measure that opening, Dr. Gill will send up a balloon, place it in the opening of the septum, and inflate it to find out the exact measurement.
So what we're going to do is put the balloon onto the wire, place the balloon across the septum, and then we will inflate the balloon, and we'll monitor with the ice catheter the flow. Once the flow disappears, we know we've closed the defect, and then we'll measure.
Now, Dr. Gill knows what size device to use and begins to deliver it.
Okay, so this is actually the device. This green part is the delivery system, and this is actually the occluder. So half of this will sit on the left atrial side and the other half on the right atrial side. So what we do is that we're going to retract this back into the delivery system, and then take this up across the septum and then begin to deploy it. This is the intraatrial septum after the device has been placed, and you can see the device is splayed. So it's across the septum and it's splayed and has sealed the defect.
This is where the defect was.
Right in there. You still see some color, but it's the major hole has been sealed.
After the procedure, Dr. Gill took some time to show us before and after images of Dovey's heart.
This is an echo just before we placed the device across the atrial septum. So this is the atrial septum you're seeing here. This is the wire across into the left atrium. And this is Doppler signal that you're seeing here, which shows that there's a free flow of blood between the left atrium and the right atrium.
That's not good, is it?
Well, no, that's the defect that she has, and what is presumed is that a blood clot, and it's not absolutely clear where the blood clot comes from, but instead of the blood clot, which comes into the right atrium, going into the lungs, and probably being not a clinical event, it actually crosses into the left atrium and then leaves through the aorta and goes to the brain. Okay, so by closing off
really
this,
bad.
yes, that's what causes a stroke. So by closing this off, it's not well shown here, but there is an aneurysm in the atrial septum, and all that means it's just a very floppy septum, and it's thought too that blood clots could form in there. Now this is after the device has been deployed. So this is the intraatrial septum here, and this is the left atrial side of the device, and this is the right atrial side of the device. So in a way, it has, and they're connected through here. You don't see the connection, but it is very well placed across the defect.
So you're having no blood flow then between the two?
Correct. That's now we're going to establish that. Just give me 2 secs here. You are seeing this is again this is with the colored Doppler. This is the intraatrial septum. This is left atrial side of the device. This is the right atrial side of the device. And you have to take my word for it, but there, although you do see color down here and color up here, it's reflecting flow in the atrium, but there is no flow across the intraatrial through the device, like you did before. So we've got a very nice result.
We'll check in with Dovey later, but now George Lackey is on the table in Dr. Issa's cath lab. In this ablation procedure, Dr. Issa will restore George's normal heart rhythm by applying heat with a laser to the affected area.
Now what we see on our screens that the patient has a lot of electrical signals. We get under fluoroscopy in the heart multiple catheters. That's where you see the dark dots. These are electrodes that will record the signals for us inside the heart. And we see the flow of electricity inside the heart. Then we try to use a three-dimensional mapping system, which you see on the top right screen, to try to translate that electrical signal timing into a color-coded map and geometric transformation of the chamber of the heart. And now the electrical signal of concern and the abnormal one is in the right top chamber, the right atrium. So we call this a three-dimensional mapping of the cardiac arrhythmia. That tells us exactly where's the source of this electrical signal and what's the target for our ablation, what area we need to damage in order to get rid of this arrhythmia. And we try to define an area that is the minimal amount of damage required to stop the rhythm, the abnormal heart rhythm. So the tip of the ablation catheter, which is this dark spot here, we deliver radio frequency energy that when it goes through the muscle of the heart chamber, it turns into heat and burn out the target of ablation where the abnormal electrical signal originates.
Oh, so you want to stop the signal from going where it's been going and create a new place for it to go. That might solve the arrhythmia.
Once we stop the abnormal signal, then the heart's natural pacemaker takes over that we were all born with. When an abnormal signal comes into a heart because of cardiac disease or some other causes, that signal is usually faster than our natural pacemaker, and that takes control of the heart rhythm. Once we stop the abnormal signal, then we go back to the default electricity, which is the normal rhythm. You see here on the left side of this screen, the electrical signal is really coming very fast in the green portion of the electrodes. That's the atrial signal, the top chamber of the heart. That abnormal signal is coming at about 250 to 300 per minute. Once we ablated the part of the short circuit, that electrical signal, the abnormal one, that stops, and then the heart goes to its natural rhythm, which is a much slower normal rhythm. As you can see, the frequency of those signals.
And the bottom green lines, those are the present heart rate?
So yeah, this is now the current heart rate. And top on the left is the atrial flutter. Once we ablate it, it stops here and goes back to normal rhythm that we're seeing now.
Normal is going to sound real good to George when he comes to. And on the day after her procedure, Dovey is getting ready to be released.
If you think about it, we've now got a foreign object in there, So what we want to do is if you're going to do any dental cleaning or any procedures or anything like that, we want to make sure that you're going to use antibiotics beforehand. I'm going to give you a card that'll kind of just tell you what antibiotics to use. So if you're going to the dentist or if you're going to, you know, go for some procedure or something like that, you can give us a call and just say, hey, is this something I need to be using it for or not using it for? And that, again, is just to try to make sure that that heals well and there's no chance of infection as well.
I already do that with my knee implant.
Yay! It's exactly the same thing then. So that's exactly what you're going to want to do, okay? Now, what we do from a follow-up point of view, we do not expect any problems at all. I think everything went very, very well yesterday. We will get you back in clinic in 1 month's time. We'll take a picture, just the echo, not the one that, you know, when they went down the throat, but just the one that goes on the top of your chest. We'll take a look at that. If everything looks good, then we see you again in a year and we'll recheck it again.
So Dovey's going home.
Right.
George is going to rest up, and it looks like he's going to go home pretty quick.
Right.
And these two individuals had very good experiences. And I guess they still have to watch out in the future, though, for these situations, because in George's situation, I guess AFib is something that could possibly return.
Right. These procedures, the ablation procedure, are about 80 to 90% successful, but there are patients who have recurrences, and there are patients who require a second procedure to maintain a regular rhythm. But it's probably the best we have in terms of restoring patients to regular rhythm over the long term. And certainly better than medications in terms of keeping them in regular rhythm.
You know, we got the chance to spend 1 week here with our cameramen and yourself and your staff and everybody here at Prairie Heart Institute. And for us, it's a real eye-opener, but for you guys, this is just day to day. This is just life, isn't it?
Well, this is our life, and it is our life, and it was an honor and a privilege to allow you in to our institution and see the work we do. And of course, the thing that always amazes me the most, you'd expect the doctors and nurses to want to help out in a situation like this, is how easy it was to approach our patients, many of whom were in the midst of an emergency, and say, hey, would you mind if we filmed this for public broadcasting and to educate the public? And I don't think we had anybody turn us down.
It's remarkable. It's remarkable. And we had such, the patients were terrific and outgoing for us too, because they described to us how they felt. They said, sure, come into the procedure, and our access was remarkable. Thank you very much.
Our pleasure.
Yeah. And I think you'd agree with me. It was an eye-opener for me. I hope it was for you as well. For Dr. Greg Mischel, I'm Mark McDonald. Thanks for watching Cardia in Any Given Week.
For a DVD copy of the program you've just seen, send 1995 to Network Knowledge, P.O. Box 6248, Springfield, Illinois 62708. Be sure to include the program name, subject, and when the program aired. You can also order with your credit card by calling 800-232-3605.